A very good morning to all the participants. We are 4 minutes to go for the webinar to start. I request you all to wait and we will be commencing soon. Thank you. And I request all the participants to mute their own mute their videos and audios. Thank you.
మనది మ్యూట్ ఉన్నదని ఇప్పుడు ఉంటుంది.
It's almost time. Can we start? Sandhya, madam?
Yes, ma'am.
Yes.
Yeah, please start, ma'am.
Gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity. A very pleasant morning to everyone. I, Sandhya Gupta, on behalf of Department of Botany, Zoology and IQAC, Kasturba Gandhi Degree and PG College for Women, is honored to extend a warm welcome to the principal of our college, Dr. P. Sunita ma'am, Vice Principal and Co-Coordinator of the webinar, Dr. Rashri ma'am, and event of the speaker, Dr. Mitnala Amasai, and all the participants to the international webinar on management of COVID-19 clinical perspective. Let us start the international webinar with Shanti Shloka, rendered by Mrs. Padmashri Madam, Head Department of Botany. Over to Padmashri Madam.
ॐ सहनाववतु सहनौ भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै ॐ शान्ति शान्ति शान्तिः.
Thank you, ma'am. As you all know, we are under the spell of the nightmare COVID-19 since the past 9 months. With increasing mortality rates, we have to prevent ourselves from this communicable pandemic disease. So here we have a very eminent speaker, Dr. Mitnala Amal Sai, who is going to enrich our knowledge on management of COVID-19 clinical perspective. Now I invite our senior faculty, Dr. R.K. Devi ma'am from Department of Zoology to proceed with the session. Thank you. Over to Dr. R.K. Devi ma'am.
Thank you, Sandhya. Good morning, ladies and gentlemen. Kasturba Gandhi Degree College has started in the year 1973 with a strength of 100 students, and presently our strength has grown to 3,000 plus. We crossed 47 glorious years of history, and our students are working globally in various countries as doctors, engineers, dietitians, lecturers, medical transcriptionists, lab technicians, banks, and many of them are pursuing their research abroad. Department of Botany was headed by Dr. Sulochana in the year 1974, and Department of Zoology was headed by Dr. Susan in the same year. India Today rating for the year 2020 shows our college is ranked 61 in arts, 85 in science, and 96 in commerce. Under the guidance of our principal, Dr. Sunita, and vice principal, Dr. Rajeshri, conveners, Ms. M. Padmasri, Head Department Botany, and D. Jyoti, Head Department Zoology, and our constant support of our management, we are organizing this international webinar on COVID-19, a clinical perspective. Ladies and gentlemen, I have the pleasure of introducing an accomplished doctor from Telangana, Dr. Amar Mitnala. He completed his medical graduation in the year 2006 from Kakatiya Medical College, Warangal, Telangana. In the year 2009, he did his master's in biotechnology from the University of Houston, Texas. Residency and training. He did internal medicine residency in Prince George Medical Center, Maryland in the year 2013. Presently, he is working as a hospitalist and a volunteer faculty for Michigan University. He is a member of acute MI committee, subcommittee, and a categorical internal medicine resident at Prince George Hospital, Maryland. He is a consultant lab assistant in Delta Computing Lab, University of Houston. Awards and achievements. He has a lot of awards to his credit, and to mention a few of them, he is won the Winners Jeopardy Award conducted by American College of Physicians at Washington, D.C. Best Resident of PGHC, Department of Internal Medicine 2011, Science and Computer Engineering Scholarship in the year 2008, Endowment Scholarship from the University of Houston 2008. While pursuing his medical graduation, he was a volunteer for Dreyfus Foundation PSBH, Problem Solving for Better Health, a campaign which involved the high school students of India, educating them from refraining from smoking in the year 2004. While he was a medical graduate in Telangana, he participated in intercollegiate tournaments held at Siddhartha Medical College, Vijayawada in 2004. He won many prizes for poster presentations while he was in the medical college. To name a few of them, treatment for strategies of colon cancer in the University of Houston. In 2005, he gave an oral presentation of differential diagnosis of ascites in Visakhapatnam. We are privileged to have you today morning, sir.
Good morning.
Thank you, sir. Now we request Dr. Amar Mitnala to proceed with his presentations. Thank you, one and all.
Thank you for giving me the opportunity to everyone at Kasturba Gandhi Degree College. It's a pleasure. I'll get started because there is a lot to talk about. So today I'll be talking about the current, like I said, there's a tsunami, COVID-19, the coronavirus disease 19 from a clinician standpoint. This is what I do on a day-to-day basis. So I thought I'll share my experiences. Let's see. So let's start with the outline. I'll give a brief introduction on what is COVID-19 and the virus. I'll describe briefly about the clinical spectrum of COVID-19, briefly about testing that we do, and of course, my main topic today will be management of the affected person in the community, and more so in the hospitalized patient, because that is what I practice. So briefly, as we all know, COVID-19 is short form for coronavirus disease 19. It actually, the cases started to appear in China in 2019. And so that's why it is COVID-19 and not 20, although 2020 has been primarily the year that has been affected by this pandemic. It is caused by this virus, the SARS COVID virus 2. It's the severe acute respiratory syndrome virus. It's called coronavirus 2 because we've already had an episode of not this magnitude, but the SARS COVID virus 1 had caused similar kind of illness in about 2000 year 2002, around that time, causing similar spectrum of disease, but it became self-limited and it did not cause as much damage. I believe about 8,000 people were affected at that time. And so this is why this virus has been designated as SARS-CoV virus 2. Currently, USA tops the list, and then a number of people affected, followed by Brazil, and then unfortunately it's India, who's currently in third position. Worldwide, there are about 21 million cases, of which there are about 750K deaths. This is data from WHO, and I'm sure this is going up. So these are just broad estimates as of now. It truly is a global pandemic. It has affected all the continents, and one and all. And these were some of the other pandemics that have affected the humanity in the past, all the way from biblical times to the more recent Zika virus, which happened in the southern Latin American nations. COVID-19 and SARS-CoV virus is the current global pandemic. Now, COVID, the difference between COVID and SARS-CoV-2, this is COVID-19 is the disease, and SARS-CoV is the virus that's causing the disease. So think about, say, something like malaria is the disease, and Plasmodium is the organism that causes malaria. Similar fashion, SARS-CoV virus 2 is the virus, and COVID-19 is the disease spectrum that it causes. So let's go to the clinical spectrum. Most of the people are asymptomatic, usually on exposure. The incubation period is about 2 to 14 days. Those who develop disease are, the risk factors are obviously the age is the biggest risk factor. The more your age is, the chances that you develop symptoms goes up. It also goes up in people who have comorbidities, which is other underlying medical conditions that people tend to have. Again, as their age increases, this include diabetes, hypertension, coronary artery disease, chronic kidney disease, and smoking. Now, when it comes to people who get symptomatic, from a clinical standpoint, we divide the people into mild, moderate, severe, and even among severe people, we divide them into critical disease. This is the breakdown of the percentages of the symptomatic cases. And the biggest thing to take account is this case fatality rate. Currently, the WHO estimates about 2.3 people who develop COVID-19 end up succumbing to the disease. Again, these numbers are changing. I believe India's rate is close to 2% or slightly less than that. So the case fatality rate is actually pretty low. It's just that the volume of people involved is so high, is that you get to hear a lot of people, unfortunately, succumbing to the disease. Let's talk about the clinical picture. Primarily, most of the people who are asymptomatic, like I told you, but those who develop symptoms, the primary syndrome is that of an acute viral syndrome. Think about influenza and all the viral syndromes like chikungunya, stuff like that. But viral syndromes are usually having fevers, body ache, upper respiratory infection symptoms like cough, coryza, runny nose. A lot of people tend to have diarrhea. What is specific for this particular disease is the loss of smell and taste sensations. Now, the other big thing when it comes to clinical picture of COVID-19 is, of course, development of pneumonia and respiratory failure. The other things that we have noticed in COVID-19 spectrum is people, about a third of them who become critically ill develop cardiac arrhythmias and what we call cardiomyopathy, which is weakening of your heart muscle. Um, Interestingly, we've also noticed that people who develop COVID-19, they are also having a tendency to form blood clots. We in the medical field call it hypercoagulability. Because of the blood clots, they can be formed both in the arterial system as well as in the venous system. Arterial system tends to cause strokes, especially in young people. And venous system, usually we see blood clots in the legs and also in the lungs. And of course, there is this entity called severe inflammatory response, where actually your body is reacting to the virus in an extreme fashion. It's similar to lines of what we call cytokine response syndrome. This is usually seen in people who receive some immunomodulatory therapy and cancer therapies, where your body is mounting an extreme reaction to the medications and to the malignancies. So this is the clinical spectrum of COVID-19 that usually we encounter in the hospital setting and when a person presents to any healthcare institution. So briefly about testing, I'll focus more about the management, but I'll go through a little bit of testing because it is a little relevant now. Usually we do testing only for symptomatic individuals, and of course asymptomatic individuals when the suspicion is high, especially if you have travel and have had exposure to endemic areas or where the virus is just rampant in the community. It also depends on whether or not there is enough testing capacity available, that you're testing symptomatic versus asymptomatic individuals. Usually the test tends to become positive after 5 to 6 days of exposure. So if you are testing sooner, um, then the chances of a person becoming false negative increases. So usually the tests start turning positive in 5 to 6 days on an average. The most common testing strategies that we are using are what are called nucleic acid amplification tests, and the most common thing amongst that is the RT-PCR, the reverse transcriptase PCR. Essentially, you're looking at the spike proteins that are present on the viral envelope. Again, different RT-PCRs test one versus more than one of those the capsid proteins, and so your sensitivities change depending on the RT-PCR you use. So now, who gets tested and such? Like I said, depends on the availability of tests and how soon the tests are coming back. The Infectious Disease Society of America has given us some guidelines on who is prioritized, who gets a second priority, and in general, in that fashion. In general, critically ill patients who are coming into the hospital, healthcare personnel, and anyone who is essentially coming into the ER, urgent care centers with symptoms, they tend to get tested. Those who are asymptomatic and or who are experiencing mild symptoms, we, depending again on the test availability of the test, we are asking them not to be tested, or stay at home and monitor symptoms. Um, so what happens to a person once they develop symptoms and choose to come into the hospital? They usually present to the emergency room or the urgent care, and subsequently the decision whether to, number one, test them, or subsequently to hospitalize them, based completely upon their symptoms, whether they are symptomatic or asymptomatic. And so the decision tree starts with what risk factors do they have. um, are they having symptoms of, number one, shortness of breath, and number two, if they are hypoxic or not. The reason shortness of breath or dyspnea and hypoxia are important, because one or two studies have shown that these are individual factors that affect the outcome of the COVID-19 disease. So people who have shortness of breath and hypoxia at presentation, they tend to do poorly, is what the studies have been showing. And so, and of course, availability of resources. I know right now initially there was this talk about flattening the curve and such. That was essentially to make sure that the healthcare system is not overwhelmed. Unfortunately, in many cases, it is being overwhelmed, and so the decision to admit and who gets admitted in which setting, in a floor setting versus a critical care setting, all of that, it all depended on availability of resources. Again, once you make a decision to admit the patient, the decision is again um, whether to you're admitting the patient to a medical floor versus the critical care unit. And of course, at the end of the talk, I'll talk about what are the criteria for discharge. But let's talk about what happens to a patient um, who comes to the ER, and now you decide that this patient does not need inpatient hospitalization. This person can go home, but you send the patient home again based on available. There are a certain set of criteria that our clinicians look for. Is number one, whether or not these people have access to telehealth resources, or are they able to get in touch with the healthcare personnel, whoever it may be, at whatever level they are, whether or not they are able to self isolate themselves from their rest of the family members, um, whether they can get appropriate supportive care at home, which includes rest, which means that somebody is able to help them feed, take care of their daily needs, whether or not they have enough medications, fluids, if they have any elective surgeries planned, we usually ask them to postpone them. Think about something like cataracts, teeth, so any kind of elective surgeries like knee replacements, joint replacements. We usually ask them to postpone the elective surgeries. Specific populations, again, this is important because a lot of people, people who have underlying disease, be it cancer, COPD, those who have had transplants in the past, pregnant women, institutionalized people, think about people in nursing homes, senior centers, um, people who are in prisons, who are in anyone who is in group setting. We take that into consideration before we send them home. And also we want them, their primary physicians who are managing their chronic conditions, to be aware that these people are COVID positive and they are being sent home because their symptoms are not severe enough that warrants inpatient hospitalization. And so we choose all of these to send people who are COVID positive to home. Now, do we send them home on any specific therapies? Essentially not. Because no specific therapies have been proven of any benefit. And I'll talk a little bit about that, about the steroids, because the steroids have not shown any proven mortality benefit or symptom improvement in people who are not needing any oxygen. And you also have to be mindful of steroids having their own side effects, especially for people who are diabetics, people who might have latent tuberculosis. Of course, said there are some side effects of steroid-induced psychosis and such. However, the steroid doses that are being used are on the lower side. So this is going to be the main focus of my talk today, which will be inpatient management. Again, like I said, once the decision is made to hospitalize, we take a decision on whether the patient goes to the medical floor, or they are critically ill to the point where they need to go to the critical care unit. That depends on how symptomatic they are and what their oxygen needs are. If their oxygen needs are on the lower end, where they can be managed using um, what is called a low flow oxygen delivery system, they usually go on to the medical floor. Once they're needing what is called a high flow oxygen, where your oxygen concentration increases and the delivery rate increases, or if they are intubated and they have a need for mechanical ventilation, they end up going into the ICU. One always have to be, as clinicians, we are always taught to keep an open mind. Whenever a person has respiratory failure and are COVID positive, you also have to tell yourself that there could be exacerbation of their underlying conditions. Say if they have pulmonary lung disease, or if they have heart disease, that can be in an exacerbated state, that can also cause hypoxia. And also you can have secondary infections or bacterial infections on top of the of the viral infection going on, and that will also play a role in how you are managing the patient. Because if you're suspecting bacterial infections, you want to add antibiotics on top of the supportive care that you give for COVID-19 people. So the most important thing whenever a person is hospitalized is supportive care. I think it is understated, and we go behind the plasma and the dexamethasone, the remdesivir, and all of it. But I think the most important thing that saves a person's life or is most beneficial is, of course, supportive care, um, which includes fluids and nutrition. And I'll talk about thromboprophylaxis, which is basically to prevent formation of blood clots in a person who's not moving much. Um, because, like I mentioned earlier, we've noticed that in people who have COVID-19 disease, the risk of developing blood clots has increased, and so we monitor for that. And as a preventive prophylactic strategy, we give them blood thinners to prevent from that happening. Now, people who get hospitalized, um, those who develop severe respiratory symptoms and this condition, what we call ARDS, which is acute respiratory distress syndrome, uh, those who have multiple comorbidities, those who have worsening inflammatory or coagulation parameters in their blood work that we do, and of course, any of those people who develop any signs of end organ damage. Think about if your kidneys are failing, if your heart is failing, and if you have more than one organ system that is failing apart from your respiratory symptoms, then all these people tend to have a poor prognosis and have a bad outcome. Um, Now, let me talk about COVID specific therapies. I broadly classify them into antiviral and anti inflammatory therapies. Antiviral are obviously you're targeting the virus. The common uh, medications that are in the news and that we all are being hearing about is, of course, remdesivir. Favipiravir is actually known in India. It is not. It is only being studied in US, but it is not popular at all. Um, Lopinavir and ritonavir is actually an antiretroviral medication which is used in treatment of HIV people. Again, the studies have not shown any benefit with it. Convalescent plasma is something that I'll talk about later, and of course, hydroxychloroquine has been in news so much. But studies in the US so far have shown kind of gone out of favor when it comes to treating people with hydroxychloroquine plus or minus in combination with antibiotic azithromycin, because it has not shown to be beneficial and it has side effect of affecting the heart and prolonging what is called a QT interval and causing more heart rhythm abnormalities. Again, anti-inflammatory medications. This is inflammation is your body trying to react and to the virus and to the disease. And so anti-inflammatory medications tend to reduce that response. So the medications that are commonly that we know are steroids, of course. Dexamethasone was the one that was studied. Tocilizumab and interleukin 6 inhibitors. So interleukin 6 is one of the major chemical, what is called cytokine that is released during an inflammatory process. There are some people who are testing the interleukin 6 levels, and people who are sick are getting tocilizumab. This is usually reserved for those people who are developing that severe acute inflammatory syndrome, which is similar to the cytokine response syndrome. But again, I'll talk about this a little because this is a little bit controversial, and I must say that I have not had much experience with tocilizumab. Um, let's talk about remdesivir because the three therapies that are important, that are currently popular and have shown some proven benefit are remdesivir, dexamethasone, and of course convalescent plasma. So remdesivir is an anti-viral medication. It has been shown to have in vitro antiviral activity, and so that's why we are using it. There was some experience from the previous SARS, the SARS coronavirus 1 and so they've started using this as a trial medication. Um, it usually the severity of the disease determines what kind of effect a person or what kind of outcome remdesivir is going to have. Unfortunately, you cannot use remdesivir if your liver function tests are abnormal, or if you have chronic kidney disease stage 3 and above, which means that if your kidneys are not functioning well and if your liver functions are abnormal, you unfortunately cannot use this medication. What remdesivir does in a person with COVID-19 disease is that it hastens the recovery, or um, if you recover, you recover quickly, when say if you were not to get the remdesivir. And so what they were the trial that have all shown is that it does not have any mortality benefit. So unfortunately, for those people who do poorly, who succumb to the disease, whether or not you get remdesivir, at this point the data shows that there is no mortality benefit. So this was the original study that was started. If you notice, it's still a preliminary report. So I'm sure as the study continues, there would be more data, and I'm sure the results will be revised, and you might have more recommendations. But as of now, the remdesivir recommendations are based on this trial. So this is a busy slide. It just shows the summary of the results and conclusion. And again, I'm just gonna this is a busy slide, but I want you to focus on this particular. Say, if you overall people who recover, they tend to recover at a mean of 11 days when compared to 15 days if you had not received the remdesivir. And this has been shown to be statistically significant. Um, and Unfortunately, for mortality, there has not been shown any statistical significance in people who receive remdesivir to placebo. Again, if you notice, the direction is towards that people are doing and living better with remdesivir. However, statistically, this has not been significant as yet. So that is what this particular slide is showing. I think the rest of the slide is busy, and I'll just leave it alone. So to summarize about remdesivir, it makes your recovery time sooner, but mortality benefit is not present at this time. Um, Coming to dexamethasone, again, it's an anti-inflammatory medication. Low dose has shown mortality benefit, which means that people have actually less people have died in the steroid, people who have received steroid versus those who have not received. And it's primarily again a preliminary report based on a United Kingdom based trial. These are the authors, and this is the study that looked into this. Again, this is the basically the results, and it's a busy slide. So what I want you to focus on uh, these data. So if you notice that the primary outcome of mortality, uh, if you see that the ratio is less, and with a confidence interval that is less than 1, which means that basically you do have mortality benefit. um, and More so, if you come to this particular area of the data, if you notice that people who are mechanically ventilated and those who are getting oxygen are the ones who are actually benefit. If you notice, this is dexamethasone getting better, and these are the placebo that are getting the supportive care. Those who did not receive any oxygen, they actually did not show much of a benefit. So it was a kind of equivocal data when it came to people who did not receive oxygen with dexamethasone. So when it comes to dexamethasone, it does show mortality benefit, more so in people who are actually requiring oxygen and those who are, of course, mechanically ventilated. So that is what dexamethasone is doing. Now we'll talk about a little bit of convalescent plasma. I know there are multiple this WhatsApp thing that is circulated about plasma donors and such. So convalescent plasma, in essence, is basically a person is affected by COVID-19 disease, or they've been exposed to the SARS coronavirus 2, and now they have developed an antibody response, and so they have circulating antibodies that are neutralizing antibodies to the virus. And so the in theory, you are taking those antibodies and providing it to the person who is affected. And so it essentially provides what we call passive immunity. It is not the patient who's developing immunity, but it is rather getting from outside. Think about mother's milk, and you're getting antibodies from mom's milk to the infant baby. So similar lines, where you're providing passive immunity. It's been shown to be maybe beneficial if you're using it early stage of the disease, where you have the virus and the patient does not have the immune response developed yet. But once, if a person has developed severe disease, or it has it's the number of days has passed from the time of symptom onset, um, the convalescent plasma is of maybe of little value, because primarily I think is because the person has already developed immunity. And so if you are adding a little more on top of it, it's not going to make much of a difference. Again, this is an investigational thing. You can make case to make case exceptions, and it has, like I said, revealed mixed results. So many studies have been done, and people are now trying to do what is called a meta-analysis, that they are trying to combine data from all the studies and kind of determine whether or not overall convalescent plasma is better or not. So far, I think the studies have been favoring, but not mixed, but not completely proven that convalescent plasma is beneficial, and more so it is beneficial during the early stage of illness. So to summarize, the therapies for a person who is admitted into the hospital, um, so people who require oxygen treatment should be getting dexamethasone and remdesivir. So that's a given for any COVID-19 patient. Again, availability of remdesivir, if that uh, is in short supply, then the teaching is, as of now, at least the school of thought is, because remdesivir has not shown mortality benefit, it has actually shown in reducing the length of hospitalization and your time to recovery. It's actually, believe it or not, the moderate oxygen requirement people who should be getting remdesivir rather than the severely sick people. Um, but if you are requiring oxygen and if you are severely sick, everybody gets dexamethasone. Again, with remdesivir, you also have to remember that if you cannot use it in people who have developed kidney disease, or if their liver functions are abnormal, and people who become critically ill usually tend to have physiological derangements of their liver. So they have more than one organ system that is involved. And unfortunately, at that point, remdesivir might not be an option, given the damage sustained to the other organ systems. Now, we can consider convalescent plasma if it is given early in the disease, but again, like I said, once the disease progresses, convalescent plasma so far has not shown any good, results. But I think I must emphasize that COVID-19, the mainstay or the backbone of COVID-19 management is supportive care. Um, and I think that's what is going to get people improved. Now, once you provide all this treatment, when do you discharge a patient? That is another important clinical things that as physicians who are treating people or treating people with COVID-19 disease, have to make on a day-to-day basis. Number one is, of course, symptom improvement. As the symptom improve, then you can start thinking that yes, this person is improving. Unfortunately, you always have to think about that there are some people who have shown improvement, they've gone home, and their symptoms have come back and they had to come back. So you always instruct the people that if your symptoms tend to worsen, or your symptoms tend to recur, then you always instruct them to come back. The other point that we use is improving oxygenation. So again, if your oxygen needs, we usually, from a clinical standpoint, we assess by two parameters. One is your what we call oxygen saturation, which is basically measuring how much of your hemoglobin is saturated with oxygen. Usually, it's a colorimetric assessment that can be done at home as well. So I'm sure you have seen those devices where they put on the fingers and they get a number. Usually it is expressed in terms of percentages. What we look for is at least 90 and above. And once their oxygen needs are about 6 liters and less, 6 liters per minute and less, is when we can start thinking about saying that these people are improving and yes, you can send them home. Again, you have to always remember that these people are sick. They do have the disease. So their ability to self isolate at home and the social support that they can get at home, um, because they are sick and they need to be tended to as well. So um, those factors have to be considered before discharging a patient. Um, Telehealth, again, being in contact with the person via telephone or via Zoom or any form of tele conferencing thing, that can provide them reassurance and see if their symptoms are getting worse and see if they need to come back to the hospital. So these resources have to be provided. And so when once the person is discharged, the other question that is a big question that needs to be answered is when is this person um, can start mingling with other people. So the current CDC recommendations are based broadly into two categories, one based on symptoms and one based on test. So there is a symptom based strategy and there is a test based strategy. The symptom based strategy says that what if you initially have mild to moderate disease, from the point where you tested positive or from the point where you had symptoms to up until 10 days, and you should not have fever for about 24 hours. And this person, according to our CDC guidelines, is no longer infective. And of course, people who are severely ill or who are immunocompromised, say diabetics, cancer people who are getting any immunosuppressive medications, elderly people, uh, from the consensus is anywhere between 10 to 20 days, and of course no fevers in the last 24 hours. Now, these are people who don't have to be tested again. The reason is, some of these people, and not all of them, most of them are testing negative after 10 days, but some of them do have improvement in their symptoms. They become normal. Um, but their tests are still testing positive. But there is some amount of, you always have to remember that the tests are actually looking for those viral capsid, the spike proteins, and the nucleo those individual proteins, and they're not actually testing that entire virus. So you might still be shedding some viral components and not the viruses in total that are infective. So the test might still be for the positive, but you no longer are infective. At least that's the school of thought, and that's what the CDC is recommending in terms
नीरज
of
उठ रे 10 वाजून गेलेत.
guidelines as of now. So these are my references, and again, I thank you all for giving me the opportunity to talk about COVID. I'll be open to questions. Let me stop sharing screen. Yeah.
Thank you, Dr. Amar Mitnala. It was indeed inculcating an informative presentation, emphasizing on symptomatic and asymptomatic individuals, prognosis of the pandemic, precautions to be taken in increasing mobility. Our participants have a few queries to you, sir.
Sure.
Question number 1. Is the virus mutating as it is spreading from one person to another?
So we are not actually testing for mutations. So from a clinical standpoint, we don't know. It is an interesting thing that some regions of of the world are experiencing severe forms of disease and some are not. Um, so to answer that question, I guess I don't know.
Right, sir. Question number 2, sir. After recovery, can a person become a convalescent carrier? If so, what is the time duration?
So, like I was talking about at the end of the talk, is current guidelines is that if you have mild to moderate disease, that is, if your oxygen requirement was not high, from the point of your symptoms onset or from the point where you're tested positive, up until uh, 10 days, and and it's not or and not having any fevers for 24 hours, um, is when a person is no longer infective.
Right, sir.
So are they convalescent? Yes, they are all convalescent. They have antibodies, but they don't have viral shedding to the point where they are infective any longer. Those are the current recommendations. Again, you can have exceptions, but the current recommendations are this. um, it's important that people who are immunocompromised, um, especially for those who are taking, say, somebody in a healthcare field who's taking care of other people, they follow a test-based strategy rather than a symptom-based strategy, because you are again coming in contact with other people. um, and so the distinction is between whether or not you are going back to a community versus whether this person is a healthcare person who's going back, or is a person that is taking care of institutionalized patients or people. Then maybe a test-based strategy will determine whether or not this person is still having that viral shedding and is still contagious or not.
Right, sir. Thank you. There's another query. How does the throat pain of a COVID patient differ from a normal throat pain person? Like, how do we discriminate between the throat pain of a COVID positive patient and a normal person with throat pain?
So when it comes to throat pain, so so there is no distinction, actually, to be honest with you. When it comes to a clinician examining a person with throat pain, uh, we the traditional teaching has been whether or not this person is infected with strep uh, infection causing throat pain. So there are criteria where we use presence or absence of fever, presence or absence of cough, whether there are exudates that are present, which are basically, think those whitish coating that you
Discharge.
develop on the back of your throat, whether they are present or not, determines whether this person gets tested for strep or not. Now, because COVID is so prevalent in the community, if a person is coming with fever and sore throat, we are testing those people with COVID, because you want to rule out what is prevalent in the community. Um, but as a clinician, we always have to keep an open mind, that there are multitude of things that can cause throat pain. COVID happens to be just one of them. Do I test people with um, you know people with sore throat for COVID? The answer is yes. At this point in time, the answer is yes. Clinically, can you differentiate? Is it COVID versus any other sore throat? Um, so I guess no. The answer is no. So you always have to keep an open mind. Usually, people who tend to develop viral infections, they tend to have body aches, fever, versus bacterial infections. Of course, they have fever. Usually body aches and such are lacking. Again, these are kind of broad things. It also depends on whether the person is an elderly person, who's demented person, who has other comorbidities. So they might not mount a fever all the time. They might not have the same symptoms. So the answer is, for throat pain, there is no other throat pain. The only distinct or unique feature that we have noticed about COVID-19 is the lack of taste and lack of smell. Interestingly, has been shown unique with this COVID-19 disease.
Right, sir. Thank you. Sorry if we are troubling you. There are quite a few queries from our participants. What is the impact of the virus on the organs in the long run for a COVID positive patient after recovery?
So I think long run, you have to define what is long run.
In the sense, once he's recovered from and he's come as negative, COVID negative.
So again, it depends on how severe your disease has been affected, and what comorbidities you had. And lot of people, actually, believe it or not, I have seen some young people who have been said, oh, you're disease free, you can go home. Young people in their 40s, they've come back with stroke. So there are a lot of unknowns when it comes to long-term effects of COVID. I think we are still in the getting to know phase about this disease. Okay. Like I said, most of the people are asymptomatic, but if you are hospitalized and if you are going home, most of the people tend to do well, especially those who are younger and those who do not have comorbidities. But usually anywhere between 2 to 3 weeks or about a month is usually this. Most of the people tend to have, this generalized malaise for.
Okay, sir. Could there be a relapse of the particular infection after getting tested as positive, after getting treated?
So this is investigational. People who are coming back, we don't know if it is a relapse of the same disease that they had, or they are getting reinfected. So these are two different things. So like I said, there have been few cases where people have been sent home. They got better, their oxygenation improved, they did well, they went home, and they had to come back because they had a late development of the pneumonia. They had a stroke. They had some complication that they had to come back again. Now, would I call that a reinfection? I don't think so. It's more of a late effect of the same disease spectrum. Now, are people who were affected, are they getting reinfected again? That is, I think, at this point, it falls in the unknown territory. We don't know yet.
Nice.
Because the antibodies, we're not 100% sure how long these protective antibodies last for. So I think this coming next few months is going to give us a good idea if the disease is going to come back again the way it did when it started. So we will know more, I think, in the next few months to come, whether this is reinfecting or not.
Thank you, doctor. Are there any vaccines which are more effective?
So right now there are no vaccines, or let me say this, there are a lot of vaccines that are investigational. So I am eagerly waiting myself to know more about these vaccines. And what would be also interesting to know, how long are these vaccines going to be protective? Because here in the US, we get influenza vaccination every year. So the immunity lasts for anywhere between 6 to 8 months, and then your body is again, naive, ready to get infected, kind of a thing. So the spectrum of vaccination, if you come to think of it, something like a chickenpox virus, once you get infected, you get lifelong immunity, versus something like a common cold. It's caused by virus. Your immunity at best lasts for maybe a few weeks to maybe a couple of months, and then you can get a common cold again. So viruses, we don't know where actually and how long the immunity is going to last. So I think those vaccines, it'll be interesting to see how long, even if the vaccines are protective, how long the protection is going to last for.
The last question, sir. if a person has COVID positive symptoms, and what are the precautions to be taken by the family members at home?
So, so mask, mask, hand hygiene, surface cleaning, um, and common sense. I think we underestimate common sense. You treat everyone like having COVID-19 or having the virus. You have to maintain hand hygiene, and you have to clean the surfaces. Of course, because if it is your own family, you have to take care of them, but you have to keep them in a separate room that has an attached, restroom, place where they can do their daily activities, um, where you can easily monitor them. You designate one person who's the most healthy person and most willing person. Elderly people, kids should be separated from them. I know it's very difficult to in tight settings, but distance is what you need from the person, and hand hygiene and hygiene is what is going to protect you and protect the others in the community, because a lot of people are asymptomatic, and even though you might have the virus, you might not know it and you might give it to others. So I think who develops the disease has been an enigma. Actually, we are only identifying people who are coming into the hospital setting, and we know now a little bit on what to do in what kind of supportive care, what kind of treatments we can try. But for unfortunately for the community spread and such, I think that's still been a challenge, more so in a populous nation like India.
Thank you, Doctor. As we are running out of time and our enthusiastic participants are posing a lot of questions, I told them probably we'll answer them in the WhatsApp, because now it must be past 12 for you, and I'm sorry for disturbing you, sir.
No,
Uh,
I agree to it.
it was wonderful lecture.
I hope it was not too boring.
No. So we really got a lot of information from it. And thank you so much, Dr. Amar Mitnala, for sparing your valuable time. Now I hand over to our IQAC coordinator, Ms. Sunanda, to propose the vote of thanks.
Yeah. Uh, Thank you, Devi ma'am. Am I audible?
Yeah.
Okay. Thank you, Devi ma'am. Very good morning to one and all. On behalf of Kasturba Gandhi Degree and PG College for Women and Department of Botany, Zoology and IQAC, I, Sunanda Geete, IQAC Coordinator, feel pleasure to propose vote of thanks. I sincerely thank our speaker, Dr. Amar Mitnala, presently working as hospitalist and voluntary faculty at Michigan University, USA, for accepting our invitation and delivering an informative exposition on this novel coronavirus, which started in late 2019 and has set off as a global pandemic. Sir has elaborated on the clinical spectrum of COVID-19, its testing process, its symptoms, and mainly on how to manage a COVID-19 affected patient. As a known fact that prevention is always better than cure, we will certainly follow precautions indicated by you, sir. Thank you. I also thank our management principal, Dr. P. Sunita ma'am, vice principal, Dr. Ashri ma'am, for their motivation and constant support in all our endeavors. I thank the departments of botany and zoology for their collective efforts in organizing this international webinar on such a relevant topic. I thank the technical team for their support in smooth conducting of the event. Last but not least, I thank all the participants for showing keen interest and joining us. I hope the objective of the webinar have been met. I thank you all. Thank you once again. Have a good day. Over to Devi ma'am.
Thank you, Sunanda ma'am. Thank you for that information. And thank you, Dr. Mitnala. And I think it must be late night to you. Good night.
Yeah, I'm going to
Because
switch
you have
off.
to.
I'm trying to see how to. Yeah.
Now, before
No,
we
again,
log in,
thank you for giving me the opportunity to talk to you all. And there's so many learned people. I feel humbled actually. Thank
no,
you so much
we
again.
are blessed to have you today here, sir.
Thank you.
Thank you.
I'm going to sign out.
Thank you. Thank you,
Sir,
sir.
Sir, please stop sharing, sir.
please stop
I'm
sharing.
signing out.
I'm trying to, it says resume share. I'm trying to.
When you just click on the share screen, sir, in your Zoom window, you will find that stop sharing, sir.
Now, before we log out, I request all the participants to submit their feedback forms, which have been posted by the end of the session, both in Zoom and chat box in the YouTube. E-certificates will be issued to you and to the participants who have registered, submitted the feedback within 3 days to your mail ID.
Vidya, are you posting
So,
it?
I've already posted, madam.
I
Ma'am,
request
in
all.
YouTube, ma'am.
I request all the participants to please
Okay.
submit their feedback forms.
Vidya, it's not coming as an active link, no?
I have posted, ma'am. You can see it's an active link.
Okay.
We request all the participants to please fill the feedback form, and we are giving you some 10 minutes time. If you have any queries also, you can please post it on the WhatsApp group so that we can ask the doctor directly. And thank you for bearing with us and sitting for 1 hour with us. Thank you, Sunanda ma'am. Thank you, Vani Garu, and thank you, Vidya Garu, for sparing your valuable time with us.
Thank you, madam.
It's okay.
All those who have filled up the feedback forms can leave then log out.